excited today because I've had the good pleasure, the honor of having met Dr. Heidi Altman some time ago last year as part of, as everyone knows, our organization has what's called the Reach Radio podcast platform for public health professionals. And we try to go locally into communities. And it was there that I first had the opportunity to sit down one-on-one and talk with Dr. Altman and to learn about the work that she is doing with Georgia Southern University. Her passion, her drive, I think it must come from having that sociology and anthropology background. She wants to get to the root of what's going on and really understand the dynamics that are happening in communities so that we can be very specific and personalized and deliberate in our approaches to addressing the challenges that we're facing. And that would be the same in maternal health and women's health. And so, it's been for years that this has been an area of special interest to her on top of the work that she does as a lecturer and associate professor at the university. And so without further ado, it is my great pleasure to introduce Dr. Heidi Altman. Heidi, you okay if I call you by your first name for the program today? Okay.
Absolutely.
All right, I'm going to, I always have tricks with trying to do the videos, so just disregard that. Before we get started, I know that you're going to show us a couple of slides as well. But before we go there, let's just begin with a little bit of a conversation around sort of a bit more on your drive. What's been driving you to go into this space at looking at women's health and unveiling these stories around maternal health? How about we start there as you introduce yourself, please?
Okay. Well, so I'm Heidi Altman, as Fran mentioned. I'm a professor at Georgia Southern University. And like in 2019, I started this project called the Georgia Moms Project in collaboration with a friend who's an OBGYN here. And I've been doing some work in the local, because I'm an anthropologist, we sort of do a little bit of everything. And so I have been working with a local African-American history museum, and my friend who's the OBGYN is on the board there. And so she and I had this long conversation about the maternal mortality issues in Georgia, which are pretty significant. We're usually the last in the nation or maybe second to last. Sometimes we go back and forth with Louisiana, but we have the worst outcomes for moms. And so as an OBGYN, she was concerned about this. As someone who has worked in a lot of other different kinds of communities, so I worked in a lot of Native American communities on issues related to maternal health, and behavioral health in general. So we started talking about it, and this is something that I guess this is where the passion comes from, which is that, people propose lots and lots of clinical interventions and they propose lots of policy interventions, but most of that is done without actually consulting with moms who've either been served or, underserved or disserved by our system here, or without really taking into consideration the things that they need or their experiences. So I brainstormed with my friend a little bit and we tried to figure out what we could come up with. And so I began interviewing patients from her practice and also interviewing patients, people who want to participate just via the internet. And so building up on all of that, we ended up collecting a bunch of interviews from moms who've been in the healthcare system in Georgia. And at this point, it's a wide variety of moms who've had all kinds of different experiences and all kinds of different backgrounds. But we're moving toward looking more specifically at the health disparities in Georgia, which are also enormous. So that's the basic underlying issue for me. So.
Wow, that's fantastic. And thank you for sharing that. And I guess, it's going into doing research. I mean, it's time. It's not only time consuming, but time is money, right? So it's a lot of resources are needed to do what you do. Yes. How have you been able to accomplish that? Was it easy? Was it coming directly through the university itself? Who sort of helped to support you along this journey?
So at this point, I mean, when we began the project, we had no support whatsoever. I mean, we really just kind of flew by the seat of our pants because I wanted to see what would turn up. And so over time, I've been able to get time and some funding from the university. They're supporting me to try to gain outside funding. We've also partnered with the Medical College of Georgia, which is the only public medical school in Georgia. And it's about an hour and a half away. So we work with them some, but there hasn't been funding through them yet, but we're working to work on funding projects together. But at this point, it's been a lot of just sort of the sacrifice of time and effort, to do. But like I say, the university supported, especially student workers and people, to help clean transcripts and do things like that. But yeah, it's been a lot of time investment for sure.
It's very fascinating. I think that, we're all just very anxious to see your insights and allow you to sort of share those discoveries. So why don't we go ahead and jump into that? The screen share is on if you'd like to present some slides. It's there for
All right, I'm going to show a few slides, and I probably will move quickly through some of them because I realize that I'm largely preaching to the choir here. So hold on one second here. Let me get over here. All right. So we have in Georgia a huge maternal mortality crisis. It's worse than the rest of the country, which is bad enough. The United States is the worst of the developing nations, and Georgia is one of the worst of the United States. So in Georgia, we have a maternal mortality rate of about 67 per 100,000 live births. And I know COVID probably interrupted this, but there's no data since 2015, really. There's no available data that's been reported out. I'm sure they've been collecting data, but and so out of those 67, 28 are pregnancy related. And so the difference between pregnancy related and pregnancy associated are pregnancy related means it happens as a direct cause or relation. It means that these deaths happen during the time that you're pregnant or postpartum, but there's no clear connection. So that could include all kinds of things that happen to women. 70% of these pregnancy-related deaths in Georgia are preventable. And so that's one of the reasons I began to wonder about what people's experiences were like. And then the other big issue is that Black women are 2.7 times more likely to experience mortality than anyone else. And so from the pregnancy-related causes. So that became really apparent. I mean, it's an obvious disparity, but it also became apparent in some of the interviews that we did in terms of women's experiences, why that might be. So in Georgia, the leading causes of pregnancy-related death are cardiomyopathy, cardiovascular, coronary disease, hemorrhage, embolism, and preeclampsia or eclampsia. And this is sort of the distribution over the pregnancy cycle. So 18% happen while women are pregnant, 55% happen within 42 days postpartum, and 27% happen in the rest of the postpartum year. Georgia is, of course, one of the states that has not adopted the Medicaid expansion with the Affordable Care Act, although there is a bill before the legislature right now to extend pregnancy Medicaid from 60 days postpartum to a year postpartum, which would be a major improvement. But even so, we still don't have Medicaid for most folks after, unless they're willing to do the kind of things. There's a waiver system in place. It's a complicated system to get into Medicaid if you don't already have it. One thing about Georgia is that everyone who is pregnant does qualify for Medicaid. So that's one thing that's beneficial. So according to the CDC model, the Georgia Maternal Mortality Review Commission established these 5 areas where they feel like they could make positive interventions in terms of clinical outcomes. And so we also looked at these for the Moms Project. So the interviews are sort of based around those 5 areas. In addition, which are, before I go too far, patient, family, provider, facility, systems of care, and then the community. And so the ones that we really focus on are patient, family, the provider, and the community. And some of the other things become issues as well, but not as much. So the CDC and the Maternal Mortality Review Commission made some recommendations based on all this data. One is that they should mandate an autopsy on all pregnancy-associated deaths, so we have some idea whether they were pregnancy-related or not. That obstetric providers should provide coordinated case management, and that is something that has been really problematic too, is that people don't know that this is happening to these patients. There's no continuity of care. They also, as I mentioned, recommended that Georgia extend Medicaid coverage up to 1 year postpartum, which is at least before the legislature now, that they use a validated instrument for perinatal mood and anxiety disorders. And that's something that A lot of women in Georgia don't have health care in general, and especially there's a huge shortage of mental health providers. And so they oftentimes go into pregnancy with mood disorders that are undiagnosed, and then those sometimes become a more significant issue during pregnancy and the postpartum period. And then finally, they want to recommend that people get better counseling and education on all reproductive issues, which Georgia is really widely variable. If you live in certain counties, you could get absolutely no sex education. You might get abstinence only education. And then some counties do more, better job, but there's a real uneven experience that women have with that. So we came up with the Georgia Moms Project, which is a qualitative research project doing interviews with moms. And so we collect 45 to 120-minute open-ended interviews with people who've had a baby since 2009, which is when the Affordable Care Act went into effect. So we were looking at one insurance condition. We don't do anything during pregnancy or the postpartum year because those are still windows of concern. So the women could still be experiencing health issues during that time. The interviews are structured around the 5 contributing factors, as I mentioned, identified by the CDC, but particularly focus on the individual experience of the person and their maternal care. And then, as I mentioned, we recruit through social media, but also through the Curtis B. Cooper Primary Health Clinics in Savannah, which is where my colleague who's an OBGYN runs the GYN clinic there. So the ethnographic interviews allow us to ask questions with follow-up questions that depend on each person's experience. And these interviews usually result in qualitative data that let us build a complete understanding of the experience that each person has. In addition to asking these kinds of questions, we also collect demographic information about people so we can look at the social determinants of health issues that arise. The survey, when the woman takes a survey, it provides her with an anonymous ID number, and then they go through the rest of the process completely anonymous. Nobody can identify them. And this way we can track the experiences of Black moms or moms who are wealthy or moms who are uneducated or educated or any combination of things to see what the demographic patterns are. And then as we are now winding down the pilot phase of this project and about to do some other expansions of the project, we've added some inventories into the survey questionnaire that let us collect things like the Adverse Childhood Event Survey, about people's experiences over their life course, and other kinds of assessment inventories. So I want to share with you some of the interviews that we, or some snippets from interviews that we have about particular issues. Of course, when a woman has experienced mortality, we don't get to talk to her. So we can only talk to people who have experienced complications or morbidity, so we can try to understand what's happening. So one of the first things that I noticed in interviewing people here is that women who are labeled high risk have to attend a different kind of physician. They have to go to a high risk OBGYN. And I took out some slides about this because it's too much depth here, but in our congressional district, which is the Georgia 12th district, there are 17 counties, and outside of Augusta, where there's a medical school, in the rest of those 17 counties, there are only 21 OBGYNs in the whole area. And that's a huge rural area that goes almost from Macon to Savannah and up to Augusta. It's a pretty big area. So if you get labeled high risk and you live in that area, it's really difficult for you to get to a high risk pregnancy center because they're only in Savannah, Augusta, Valdosta, Atlanta, and Macon. So if you live in the rural areas, you have to drive a great distance, and Georgia is a huge state. So the first person that I interviewed said, okay, so a big obstacle I had once they transferred me to Savannah full time, like they handed over my care, was it was hard for me to get down there. And I had to start going twice a week, well, once a week and then twice a week. And then it was, gas to get down there. I wish Statesboro had I wish the high risk people had 5 doctors. I wish 2 of them could come down to Statesboro at least. Yeah, this was my biggest obstacle while pregnant, to make it back and forth to Savannah. And I had to buy medicine, and the insurance kind of covered it, but it didn't cover it all the way. It was medicine that I had to have. I had to take it, for him to come. So this is a young woman. She was, I think, 18 or 19 years old. She'd had a miscarriage. She had to have a cervical closure because of the previous miscarriage, was because her cervix wasn't staying closed. That failed. And when that failed, she was referred as a high-risk patient. And she was had a real difficulty. She was living in pretty extreme poverty with very little support. So it was really hard for her to get to her care provider, especially toward the end of her pregnancy. Oh, she also ended up driving herself from here to Savannah, which is about an hour and 20-minute drive in labor in the middle of the night. So it was a pretty hard situation for her. The other thing that came up regularly, and I think this is an issue of miscommunication between women and their providers, is that there were a number of women who had emergency C-sections and they were not really aware of the things that may have gone into that, and they were not really prepared for that very well. And I think this is an issue of communication primarily. So she says, he, referring to the doctor, he came and told me, your epidural is not working, obviously, because you can still feel us pinching your legs. Then he said, so we're just going to put you to sleep. We're going to get the baby out and everything's going to be fine. He said, I'm going to let your husband can't be in here while you're asleep. So we're going to let him come in here and give you a kiss. And then we're going to put you to sleep. It's going to be just fine. And my husband came in and he gave me a kiss and then he left and I laid there and I just cried. I was so scared because my doctor had told me we were avoiding a C-section because I had been on all these blood thinners. So I just laid there and I had no control over anything. My arms are strapped down and I just laid there and cried. And I just prayed because I thought I'm going to die. So she had a very unexpected C-section after having been told that she shouldn't have a C-section. And so there's this feeling of desperation and loneliness that comes up again and again in these narratives, whether it's about emergency C-section or a number of other things. Another issue that gets women labeled high risk by doctors is the fact of their BMI. So their body mass index can get them moved into a category of high risk that then triggers these other things that I just mentioned. So this person said, so I tried to get in with one doctor in town and they wouldn't take me as a patient because I was overweight. They said, basically, you're too fat. We can't see you in this office, which was devastating. I cried and cried and cried. And I thought, oh my God, I'm going to have to go to Savannah to even get care. And that was really embarrassing because when everyone that I talked to would recommend this place. And so when they ask, why don't you go to this doctor? I don't really want to be like, oh, because she won't see me because I'm fat. Like that just wasn't on my list of priorities to share with people. So finally, I found another doctor who did do high risk pregnancies. So she found one here in town, apparently. And I understand why doctors are concerned about this. But by the same token, the patient sometimes has additional, mental health related issues or other issues in terms of their own ability to get care that are affected by these decisions. Another issue that came up repeatedly with women is the idea of the culture of care. So how doctors actually care for their patients. And so this person said, doctors should spend more time with their patients. I've never gotten more than 5 or 10 minutes ever. They don't know. It's almost like you don't have any say in how it's going to go down. But they can do things that are just really awful on their own say because they would all throughout the last pregnancy. I was having gallbladder attacks and I really wanted to get the baby out so I could get the gallbladder out, right? And so from about 38 weeks to 39 weeks, I just kept begging, please, please. And my doctor's like, if you get the gastroenterologist to sign the note, well, then he signs it. And then he calls and says, well, actually, I changed my mind. So it's just up and down of like, you're delivering tomorrow. Oh no, you're not delivering tomorrow. Or like, I just feel like once you're past 38 weeks, no one cares. So this feeling that doctors don't listen to their patients comes up again and again and again. The other thing that comes up is this idea of personal autonomy, like people feeling like they have control over their own situation or their own body. So the first example of this, we have this woman says, I feel like we should have some say. Yes. Like, don't get me wrong. I really don't like the idea that people are able to say, I want to have a C-section, but damn it, it's our bodies. If I didn't want to have a C-section, but if I had, why does Joe Schmo get to decide if I can have one? But like, I don't have any say in that. So I'm really frustrated about the level of women's autonomy. And then also, I don't think they pay any attention to us. And then the second example of this, during the labor of my second son, I was in a weird position where, my mom was there advocating for me, which was wonderful, but I really didn't know what my rights were at that point. And women should know what their rights are to bodily autonomy, even at 21 years old, even at 15 years old. Because if you get into this hospital, all right, and let's say, you have a 15-year-old, okay, it happens and it's sad, but it happens. And that's where my passion is young pregnant moms. These women, these young moms who are no longer children, are about to bring children into the world of their own, have no idea what rights they have to their own body. And then the last couple of things are about mental health. And this is, again, a recurring issue for lots of folks. And this first person said, I think one big thing that needs to be considered would be the mental health of the mother. And there's resources that are handed out at either when you're getting ready to be discharged from the hospital or at your 6-week check, that there are resources there for you to reach out to, because not every woman is going to feel comfortable to say, hey, I'm having some crazy thoughts about my kid, or I'm feeling really, I don't know, I really don't like myself and I just want to hurt myself. I feel like they're not going to be able to just speak up and say that, right? But if they have the resources there, they're able to take them home and look them over, then they might say, okay, I have this. I can reach out with someone and tell them what's going on. And of course, there are providers that provide these things, but she didn't get provided with these things. And then the final narrative here is about mental health also. And she says, I think if somebody said, oh, if you'd like, you can see, for free, you could see a mental health care, you could see a psychiatrist or a psychologist or even a counselor. And if I had gotten some support to go talk to somebody, I think that would have helped me a lot, and especially in the first 6 months. And this is kind of a nerdy, weird one, but I think I would have loved to have had somebody, we'd read books and we'd known everything, to have somebody, and not necessarily to the house, but somebody other than the doctor who would have been able to come and say, like, oh, well, what do you guys do? How's your life? How are you? So just that personal touch, feeling of being looked after. And one of the things that you notice if you look at comparative data from Europe, for example, is that most of the countries in Europe have aftercare that's provided by midwives or nurse practitioners, or sometimes even doctors who come to the house for different periods of time, depending on the country as well with that. So one of the things also that I have cut out of this that I'm going to just briefly mention is that there's a huge provider shortage here with maternity care, but also with psychiatric care, counseling, psychologists, whatever kind of mental health care you can imagine, and even family practice docs. So there's a huge shortage in care and an enormous lack of diversity in care. So in our congressional district, again, at 17 counties in this area, of the 25 doctors that are in the areas outside of the medical college, 90-something% of them are men, 90-something% of them are over 55, and 90-something% of them are white. So this is a disconnect that's pretty significant between the population here. And also they're about to retire. So we won't have those folks either. So one of the things I'm doing is working with the Medical College of Georgia to help train doctors in some of these qualitative methods and make them aware of some of the issues that patients in Georgia, especially in maternity care, are facing. And then also that has been an avenue to try to increase the diversity in the workforce. MCG has been very active about trying to recruit and retain students and faculty who diversify our. So the project began with the Curtis V. Cooper clinics in Savannah and the Will Hill Heritage and Renaissance Center, which is the museum I mentioned, in Georgia Southern. Last summer, we started this partnership with the Medical College of Georgia. They've got campuses in Savannah and Augusta. And then basically we take third-year medical students and we have them participate as interviewers and also data analysis and all kinds of other aspects of the project. And then they also get to develop their own questions. If they want to, they can develop ideas related to the MOMS project or go on and do their own things as well. And this year we may actually be able to capture some European data through this partnership because of a partnership that they have with some hospitals in Scotland. So future plans, we're going to continue collecting interviews and building the context for what we know about the lived experience for people who receive maternity care in Georgia. We're going to apply, one of the big next steps for the project is to really address health disparities. And so to that end, we've convened a coalition of women who are all African-American women who have extensive social networks and who have agreed to be both an advisory council for the project and also community outreach facilitators so that we can reach African-American women and other women, but particularly African American women because of the disparity issue. And then to collect 200 African American women's narratives in a specified period of time in about 2 years, so that we can have that whole big body of information about what's actually happening to women and their experiences. We'll continue to apply for grants. We will also, we're working on articles about this and presenting at conferences and all the kind of things that you do for research. But that's all I have to share for out of the PowerPoint. I won't hold you hostage to PowerPoint any longer, but I'd be happy to either answer questions or have discussion about any of this.
I have to say, wow. So I think we need to give everybody a moment of pause to just take a breath.
Okay.
I have to also beg for forgiveness because I probably should have warned folks before we had started that this is going to be a little intense. It's intense. So let's just give folks just a moment to gather themselves. And while we're doing that, I have to, again, thank you, Heidi. The information you've given, it's so tragic. It's even more unfortunate when probably some folks who don't have their video on, likely their heads were nodding or they were shaking in disbelief. But that these are the stories that we have to, that we hear and that we have to be able to bear so that we can get to the prevention, right?
Yeah, right.
I have a hand raised, so why don't we go ahead to that? And Jen, you'd like to come off of mute and ask your question.
Thank you. Thank you, Dr. Altman, for your research and your work in the community, working with the underserved women. My question is, so how do you involve with the women who participate in your project after the research is done? I know that you have planned to publish journals and your findings at at medical journal, but what do you have any plan how to keep the community stay involved, and how and beyond using the data for advocacy work to advocate for culturally responsive care and support? Any insights on how to continue your community engagement?
Yes, so partly this involves the medical college and getting these medical students involved and getting them trained, and also getting them aware of what's happening so that the new doctors coming up will be, better equipped. But also through this network of women that we're putting together, we're trying to do more. The goal is to do sort of patient-centered education, and then recruit them to be interviewed, of course, but also build these networks as we go. I have several different interventions in mind, like for these women who are experiencing the isolation of living in rural Georgia, the isolation of living in poverty, the isolation of having providers who not listen to them. So we have a whole bunch of ideas about what we're going to do for that. And we're just, again, trying to put all the pieces together. So if you have suggestions or if you have ideas about things that would be helpful, please let me know. One of the things that we are trying to put together is to basically have women support one another. So our provider shortage here makes it so that providers really cannot take on anything else. In a lot of places we have like centering pregnancy pods and things like that, where the doctors take on these groups of women, and that's really been successful. I think here it would be much more difficult because each of the providers is stretched beyond. And so what we're trying to do is put together something similar where women going through pregnancy would have a virtual connection with one another and maybe a facilitator. So we would train a facilitator or have a facilitator go through doula training or breastfeeding training or some, different kinds of things that might assist the moms in the project, in the pod, and then put them in pods depending, on where they are in their pregnancy when they get entered in, and then have them have that support all the way through their pregnancy, labor and delivery, and postpartum year. So they would have other people in a similar situation to talk to relate to ask about, is this weird, this thing that's happening to me? So they don't have to go all the way in to the doctor or whatever, so it would be sort of a communication thing, but also like a symptom checking thing, and also having somebody there who knows a little bit more to help. So, but that's one of the things that we have in mind. I don't know if that answers your question.
Yeah, I was going to put in the chat box. We found we're encountering similar situation in the Asian population because, Asian Americans are 3 times less likely to seek mental health services than the other population. Yeah. And we found that a peer facilitated support group will be more beneficial or effective than like the typical medical, clinical setting. Yeah. And also right now we know that the wait for mental health services through telemedicine is like from 2 weeks to 6 months long. So
and here it's almost even worse. I mean, I don't know. I if you go to your provider and you get referred for postpartum, you get referred to a clinic, but typically you have to just go and wait at the clinic, right? So there's no like immediate care for you. There's no, I mean, it's a very complicated system to get the care that you need when you're probably not in the right frame of mind to have to navigate that system. So it's good to have peer facilitated works like this as well. And I think it's great. It's great to hear from you that it's working in your community as well. So.
Yeah, and it's difficult because I know in certain Asian culture, we don't even have a word to describe postpartum depression.
Right. These are great points. And anyone else have any? We're coming close to time, but I would like to at least entertain 1 or 2 more questions if there's a little brevity to them. Anyone want to?
Dr. Altman, this is Abe Bonner. I do have a question in regards to, are you looking at any type of technology to solve, I mean, these themes that you're coming up with, a lot of them could be assisted through remote patient monitoring. Yeah. And the dynamics of remote patient monitoring, have you all looked at that as a possibility?
We haven't. So there are, like at our hospital in Savannah, they do have like their own app for like kick counts and stuff like that, where people can do that. There's nothing that I'm aware of, right? I mean, one of the things that we've been talking about is trying to figure out a way to put these women in these digitally assisted groups, which doesn't seem like a lot, but we would have to have, I mean, a lot of these women don't have access to the internet, right? So we live in a digital divide here. And so a lot of the women don't have a phone that's not paid by the minute, or they don't have a phone that has internet access that's not paid by the minute. And so one of the thoughts that we had was to put, this is, at this point, it's really just me by myself. So these are all the things that I want to do, right? So I would love to have a grant or some sort of other kind of facilitation of this, where we could provide women who sign up for this a device and service for the period of time that they're in the cohort. And that way they don't have to worry about any of that. And I don't care whatever else they use it for, but at least they would have it for that, right? And then, other things like, other kinds of incentives like diapers and things like that, which are also hard to come by around here sometimes. So, but yes, I mean, and PCORI is the one that we're looking at right now. Whoever put that, I mean, I guess that was Jen to you. So yes, we're looking at PCORI and we're looking at other opportunities. It's just been, at this point, it's been me trying to process the data and also trying to get everything. So, but yes, the partnership with the medical school has helped because it has made it so I have more hands on deck with me, which is helpful. So, but yes, I agree that telemedicine. Now I do know that my friend who's a doc doesn't necessarily want more data coming in because she's got data plenty and she doesn't have enough time to see the people that she has to see. And she also volunteers as a hospitalist in South Carolina where they don't have enough hospitalists. So, I mean, it's a real crisis down here, you know, and I'm sure it's that way everywhere, but it is bad here. So, and Georgia has closed more rural, I mean, it's a huge state, 159 counties, and they've closed more rural hospitals in the last 10 years than they have opened for sure. But yeah, there are areas of the state where there's one OBGYN provider in a 2,700 square mile area. So it's rough, but the digital thing would absolutely help. And it's on my mind.
And Dr. Altman, hi, I'm Elizabeth Frazee. I work in Washington, and I'm one of the co-chairs of the MATCHCoalition. And Congress has just passed an infrastructure bill that has $65 billion in funding for broadband. And
we were anxiously awaiting it.
Yes, and your Georgia state legislators need to be hearing these stories, because the state is going to have a lot of say on how broadband is rolled out. And some type of pilot program would be phenomenal. That would maybe help women who are in places where they can't get access.
We just with COVID, I wrote a grant for the museum that I work with, because kids in that community completely fell off the map during COVID because there is no Wi-Fi other than the school. But when the school is closed, the Wi-Fi goes away, or McDonald's, but there's not even a McDonald's out there in some of these areas, right? So we got broadband Wi-Fi added to the museum so that it covers the whole campus, which is in the middle of this community. So people can come there and use the Wi-Fi to do stuff like school or whatever. But at the same time, that's the, you know, it's a desperate need. And if you have any suggestions about how I can get to the right people, let me know.
Okay.
I mean, please do.
Yeah, Dr. Altman, I actually know the health staff for Senator Awesome personally. So if you want to shoot a quick email after.
That would be fabulous. And I love our two new senators, but they also, I know, have everything, everybody's reaching out to them because they are actually doing stuff. And so I don't, it would be good to have another connection to them. So.
Well, the money's already been funded, right? So states are going to get the pot, and the states are going to decide how it's allocated. So this really, at this point, is a huge state issue.
Yeah. And our state, I don't know if you know anything about our state, but it's an issue. Our whole state is. But yes, our governor is, I mean, I'm sitting here in my state office, but it's a hard nut to crack to get into the right people, I guess, in the state of Georgia. So if you have ideas, thank you for, everyone that's saying nice things in the chat. I appreciate it. But anyway, go ahead. Other questions? I'm sorry, I don't want to keep you all too long either.
I know, I can't believe the time has gone, but if anyone does have a burning question that they'd like to make, looks like we're at a good stopping point. I'm going to allow Elizabeth to wrap it up for us today, if you don't mind, a little super quick recap, and I just say I'm looking forward to seeing everyone in March at the Maternal Health Influencers Luncheon. Elizabeth?
Thanks, Fran. And Dr. Altman, thank you so much for your powerful stories. I think this is the first time we've had an anthropologist and participate in one of these conversations. And you bring so much focus to why the MATCHCoalition is doing what we're doing. So your stories will help drive us, and really appreciate the important work that you're doing. When I heard the story, one of the first stories you had about the woman, the 21-year-old who had to drive herself to get medical care, and then when she delivered, she was in labor and had to drive herself hours. That's something that should not happen. And there are solutions, and thank you for doing all the work that you're doing. And I too want to encourage everyone to attend the match events at HIMSS. The 15th and 16th, you've got the links, and we just appreciate the support of everyone who is participating in the coalition. Thank you.